Hello, and welcome to the latest installment of the CalHIPSO monthly webinar series, this month on establishing trust for behavioral health. As you know, this is a monthly series. We try to look for hot topics to bring to you every month, and I think there's probably in our world right now possibly no hotter topic than behavioral health. So we're very excited to bring this presentation to you, and we'll get started in just a moment. A few housekeeping items before we get started. Just so you know, all attendees, as the little voice that starts the webinar said, all attendees are in listen-only mode. Your lines have been muted. If you do have questions that you would like to ask during the presentation, you can enter them in the question box that you should see on the right side of your screen. And we will try to leave about 5 to 10 minutes at the end of the presentation to get through as many questions as we can. I always like to try to head off what we know will be the number one question, which is, yes, this presentation will be made available after the end of the webinar today. We will send out a follow-up email in the next couple of days with the presentation. You can also find recordings of all of our webinars on the CalHIPSO webinar channel on YouTube. So if you go on YouTube and search for CalHIPSO webinar, you can see all of our webinars dating back to the fall of the year before last. So if you missed any of them, or if you miss any of them in the future, by all means, look at our YouTube channel and you can find them there. So just a second, and there we go. Because we do a lot of folks in these webinars who maybe heard about this webinar through some other channels, we always do like to just mention real quickly about CalHIPSO and who we are. CalHIPSO was founded about 10 years ago through a joint effort of the California Primary Care Association, the California Medical Association, and the California Association of Public Hospitals and Health Systems. We were originally founded to be the federally designated regional extension center, one of 62 organizations so designated. And we, in that role, assisted providers from almost every part of California to adopt electronic health records and achieve meaningful use. Nowadays, of course, as meaningful use is winding down, CalHIPSO is branching out into many other areas. We are still doing a little bit of work. If you're still in the Medi-Cal meaningful use, or what's now called promoting interoperability program, and you still need some help, we are still helping providers through the California Technical Assistance Program. And as many of you may have seen last spring, we launched a very exciting partnership to help providers organize into accountable care organizations using practice transformation support specialists here at CalHIPSO. To date, CalHIPSO across all of our programs has helped a little over 13,000 unique clinicians, helping them earn more than $300 million in federal incentive dollars. And we're very excited and very proud of our track record and very much looking forward to the future. And today, we are very excited to be joined by Mark Elson and Karen Boruff from Intrepid Ascent. I feel like I need to put in a little plug that Mark Elson is in fact a former CalHIPSO employee who's gone on to much bigger and better things in his own shop. But when I looked around the landscape of what this webinar would be, I knew we really needed to pull something on behavioral health. I knew Karen and Mark are really the experts and the go-tos in the world of health IT around BH. So I'm very excited to have them as our faculty today. So Mark and Karen, with that introduction, I will pass it off to you and take it away.
Thanks, David, and everyone at CalHIPSO. Can you hear me?
Yes, we can hear you great, Mark. Thank you.
Excellent. Well, it is a pleasure to be back in the CalHIPSO sort of family. And I also wanted to share that David and I served together on the board and executive committee of the California Association of Health Information Exchanges, and you at CalHIPSO may not have visibility into that part of his work, but it's been remarkable how quickly David has immersed himself in the world of HIE as well as the world of EHRs, and it's a real pleasure, David, serving with you in that capacity. And thanks for the invitation to join you all today. So Karen and Boruff and I are going to be speaking, really focusing on some policy dynamics related to behavioral health services in California, and also changes nationally that impact California, the services here in California. I did want to say, well, a little bit about us, and also give Karen a chance to introduce herself before I pass it off to her. So if we can just go to the intro slide on Intrepid Ascent, I'll do that, and then Karen can introduce herself. So we are a professional services consulting firm. We're based in the Bay Area, Berkeley, and also in Sacramento. And we work with communities of healthcare providers and their partners throughout California, and also in some other locations, including New York. We do a lot of work to really support the integration of really to support data integration in the context of the integration of healthcare services more broadly. And that takes many forms, from supporting health information exchange to the adoption of analytics and care management and other collaboration tools, to working on using technology for quality improvement, and also consulting related to user experience of technology. So please check out our website if you're interested in learning more. And Karen, can you say a few words about to introduce yourself?
Sure. Thanks, Mark. So I'm Karen Boruff. I am Managing Consultant Health IT Policy with Intrepid Ascent. I have been working in this space for a little over 12 years. My expertise is in the legal and regulatory landscape, and privacy and security policies and regulations. And really, I like to say I, in particular, but all of us at Intrepid, I strive to help clients get to yes. I think we all know that the laws and regulations and policies and this whole landscape of data sharing, particularly around more sensitive information like behavioral health, is really challenging. And a lot of times we get stuck on what we can't do instead of focusing on what we can do. So that's really what I try to do. And so I have spent the last several years really helping clients and others to understand really break down the laws and understand, what they mean, and then help, find a way to share data in a way that meets the goals and objectives, but in a secure and confidential manner that still falls within what is appropriate. So I'm excited to be here and talk with you all a little bit about just the overall trust framework for data sharing. I'll just talk really briefly about the kind of the fundamentals, or the building blocks, as we like to call them, not just for behavioral health, but for data sharing in general. And then we'll dive into some really important changes that are happening both on the at the state and federal level related to behavioral health information. I think, as David said at the top of the call, this is a very hot topic right now, and there's a lot of change happening. And so hopefully what we can do today is just shed a little bit of insight, share a little bit of what we know is happening. And of course, it could all change tomorrow because that's the nature of this space. But we just are excited to share kind of what we know and some insights into what we're seeing in this space. So with that, I'm going to just again give just a quick intro or spend a couple minutes talking about the trust framework for data sharing. I think, one of my favorite sayings is that data travels at the speed of trust. And I think that's really powerful because really the first step in any sort of initiative where you're going to share information, having a solid foundation of trust and collaborative relationships among those who will be involved and accountable is really important. This is true, as I said, for any kind of data, but it is especially true when we're talking about mental health or substance use disorder treatment information. Excuse me. So just real briefly, I think by now we have all heard about the importance of addressing social determinants of health for improving health outcomes and reducing disparities. The deeper that we dive into understanding what those impacts are, the more that we understand the policies and practices in non-health sectors have a significant impact on health and health equity. Those responsible for caring our most vulnerable consumers can no longer work in silos, as has been happening. And this emphasis on addressing the social determinants of health is really driving innovation in care coordination and data sharing across sectors. So multi-sector alliances that bring together providers, community and social services organizations, local government, and public health entities, among others, really can promote purposeful data sharing to create new insights, identify opportunities for early interventions, and again, reduce the silos of information that have been happening. Community data sharing initiatives such as California's Whole Person Care program can improve both individual and population health, affect change at the community level, and really drive sustainable resources and community partnerships. While the integration of behavioral health, physical health, and social services is critical, we've been talking about it, and the conversations just continue to pick up, but it introduces new players to the healthcare ecosystem, and it can be challenging for providers and those caring for the population to build trust among one another, particularly, as I said earlier, when it's still a challenge to know when it's legal to share information. Confusion around state and federal laws and regulations, again, particularly around sensitive behavioral health information, can really lead to a reluctance to share important clinical information, even when it is permissible. So cross-sector data sharing initiatives really succeed when there is a shared goal of building a sustainable and extensible trust framework that enables appropriate data sharing between partners. These integrated data sharing networks integrated data sharing requires a network of really committed partners who have a shared vision, clear and well-defined use cases, strategy for data sharing and data governance, and ultimately trust with one another. And the building blocks of this trust framework include governance, which is shared leadership, accountability, and decision-making, data sharing and other legal agreements, patient consent, and having the patient involved in those data sharing decisions, and the policies and procedures that govern how data is shared and the terms and conditions for how everyone is going to behave in the data sharing framework.
Hey, Karen, this is Mark. Hey, Karen, before you jump to, I just go back. I want to add one comment on the last slide that you and I have talked about a lot, the trust framework slide, which is that historically in California, health information exchange organizations and provider organizations that connect to share data, clinical data, through various mechanisms, have typically had an opt-out approach sanctioned under HIPAA. And one thing that we've seen in work with multiple whole person care pilots in the state that have moved aggressively towards data sharing across sectors is that there's a higher bar now that now that healthcare providers are connecting with, for instance, housing, partners in housing and social services, in addition to, of course, behavioral health. And most of the pilots in the state have had an opt-in policy and are getting individual consent or authorization for data sharing, both clinical information, but also SDOH type information for data sharing across sectors. So we're watching that trend, and we're wondering, we ask ourselves, will the demand for coordination of services across sectors and therefore data sharing across sectors push the historical approach that's been taken toward consent in the health information exchange, clinical health information exchange world in California? Will we see a change toward more active seeking and gathering of individual consent moving forward? So that's just something I think for all of us to watch, and we certainly are tracking it. Thanks, Karen.
Yeah, no, you're welcome, Mark. I think that's a really good point. If you've been involved in HIE or privacy or pretty much any health policy work over the last 8 to 10 years, you know that the topic of consent for data sharing with HIE has been a really hot topic, and it was debated for many, many years. And I know I, for one, don't want to revisit that debate, but it is, as Mark said, pushing, I wouldn't say forcing, but, there's a potential for some shift in the model, particularly since traditionally clinical health information exchange has been able to leverage the treatment exception in both HIPAA and the Confidentiality of Medical Information Act. But as Mark said, as we move beyond the walls of hospitals and clinics and traditional healthcare providers to bringing on new partners, that has to shift. And so we're watching that, and that's a big part of what we do with our clients is working through that, and as I said, navigating the laws while still getting to yes. So speaking of laws, let's talk about some changes that we're seeing in both the federal landscape, and then Mark will talk about the California landscape. So I think most everyone is probably familiar at some level with the federal regulation 42 CFR Part 2, which is designed to protect the confidentiality of substance use disorder patient records. It was originally enacted in 1975 at a time when there was not broader privacy and data security standards for health data. There were privacy laws on the books, both at the state level and the federal level, but they weren't specific to just, as it says, kind of specific healthcare or broader privacy data, or health data. And so what it does and what it was designed to do is prohibit treatment treatment programs and certain other third-party recipients of information from disclosing patient identities or records related to SUD treatment without written authorization, except in limited circumstances such as a medical emergency, qualified audit, or research. 42 CFR Part 2 does not apply to every record maintained by any healthcare provider. Entities subject to Part 2 must be federally assisted and meet the definition of a Part 2 program. And really, that just means that if a provider holds themselves out as providing substance use disorder treatment services and they receive funding from they're federally assisted, they receive any kind of federal funding, then they are subject to Part 2. And the protections under 42 CFR Part 2 follow the data, meaning that any downstream entity that receives Part 2 data is required to protect it the same as the originator of the data. So disclosures that are made must be accompanied by a notice advising that any further redisclosure is prohibited without consent, and a recipient may not redisclose that information except as permitted. So that means without that a recipient of 42 CFR Part 2 SUD data can't redisclose the information unless they also meet a legal exception or they have authorization from the patient. Sorry about that. My mouse is a little sticky. So in recent years, SAMHSA the Substance Abuse and Mental Health Services Administration at the federal level, has undertaken efforts to update Part 2. And they say that their primary reason for doing this is to reflect the development of our healthcare models, like as we've been talking about, these more integrated healthcare models and the growing use of health information technology to exchange patient information, as well as just the changes in laws and regulatory actions that have been implemented since 42 CFR Part 2 was first implemented. So the biggest changes really started in 2017 and 2018 through 2 final rules. And really the bulk of the changes during that time was changes to consent requirements, so changing what needs to go on the form. It added security provisions to more closely align with the HIPAA security rule, and it revised some definitions, particularly around what a treating provider relationship is and who is a lawful holder of the information. What did not change was who is subject to Part 2, what and how the information is to be protected, as well as the prohibitions on redisclosure. And ultimately, SAMHSA's goal with these changes and the most recent changes is to provide greater flexibility in disclosing information while still continuing to protect the confidentiality of SUD records. So following the 2017 and 2018 rules, SAMHSA had indicated that they intended to continue to monitor Part 2 and the implementation following the updated regulations, and also to explore potential future rulemaking opportunities that would better address the complexities of health information technology, the changing patient privacy landscape, and interoperability of information within the constraints of the statute. In addition, the opioid crisis in particular has highlighted the need for continued updates to Part 2. So in 2019, just about 6 months ago or so, SAMHSA issued a notice of proposed rulemaking with a public comment period that proposed changes to better align the needs of the individuals and those who treat those patients, help facilitate the provision of well-coordinated care, and ensure appropriate confidentiality protections continue. And really what, unlike the previous final rules in 2017 and 2018, the most recent one really took a step in better aligning Part 2 with HIPAA, because they, as many of us know, there's very little alignment between the two. So whereas both regulations protect patient privacy by regulating the way information can be disclosed, HIPAA applies to many types of patient information, not just SUD, and generally is less protective than Part 2, particularly around privacy. And unlike HIPAA, Part 2 requires patient consent for disclosure of SUD information for treatment, payment, or healthcare operations. And again, as we know, or many of us know, in the HIE world, we rely on that HIPAA treatment, payment, operations exception to share clinical information among providers. And so the integration of Part 2 information in particular, it can be really challenging to navigate this when you have two different approaches or two different requirements for patient consent. So a little bit more in detail on exactly what SAMHSA has proposed in its latest changes to Part 2. There's more, but this is just a snapshot of what I think are the most relevant to this audience. And the first one, it has to do with applicability and redisclosure. So SAMHSA is proposing, or really what SAMHSA has done, which I found interesting in reading the proposed rule, is they seek to clarify in many ways what they believe is already in the regulations. And so it's some of the wording that they use is really telling that, well, we hope that this will clarify what's in the regulation, or what, clear up confusion. And one thing that has continued to linger is that what records are subject to Part 2, particularly when it's a non-Part 2 provider that is involved in the care. And so what SAMHSA says is that records created by non-Part 2 providers, when in the course of their direct patient encounter, encounter in treating the patient, their records are not subject to Part 2 unless they receive data from a Part 2 provider that is, quote unquote, incorporated into the records. And incorporated is still an open question. But basically, just having a record from a non-Part 2 provider is not subject to Part 2 unless Part 2 information is received and incorporated into the record. Now, if a provider can segment the Part 2 records or the data, then those records, the new records created, would not become subject to Part 2. So really, they're just clarifying that just the fact that a non-Part 2 provider has data does not necessarily make the record subject to Part 2. It depends on how the data is integrated or not into the record. The other,
Karen, this is Mark. I just want to add to that, just for folks, that it's hard to guess at a percent, but we're not, just want to clarify once again, we're not talking, so that Part 2 only applies to substance use disorder treatment information from Part 2 programs. And so let's say if someone is treated for an overdose in a hospital emergency department, we would expect that information is not subject to Part 2. And so in HIEs and other data sharing networks that are operating in California, there's a lot of substance use related information that's being exchanged under HIPAA, under HIPAA essentially. And but there are, we're seeing, and in some ways, an increasing number of organizations calling themselves out as Part 2 providers for various reasons. And so this is and those entities now are seeking to be able to share data with non-Part 2 programs as well. So Karen, thanks. Back to you. Just wanted to give that example.
Yeah, no, thanks, Mark. That's a really important point. And, again, even as we continue to work with communities and providers in understanding the regulations, that's a constant thing that we try to remind folks, is that it's not all SUD data, it's only SUD data from Part 2 programs. And so, but that's a common misconception, and I think exactly why SAMHSA went into such detail in trying to clarify and clear up confusion around that. So another important provision has to do with consent requirements. So now a patient, or under the proposed rule, patient may consent to disclosure of their SUD treatment records to an entity such as the Social Security Administration without naming a specific person as the recipient. And so that's a really important change, as many of us that work with the consent forms know that it can be really hard to identify and name a specific recipient. And so having that relaxed is an important, it helps alleviate that constraint. The other thing that's interesting in this proposed rule is permitted disclosures with consent. So they, in the previous rulemaking and regulation, what constitutes payment and healthcare operations, the examples of those activities lived in the preamble, and so it left still confusion about, well, if it's not listed there, then what does that mean? Is it still work? Or and so what they've done is they've moved that into the regulation text to make it more explicit on what does it mean for what constitutes a disclosure for the purpose of payment and healthcare operations. Also, again, going back to the opioid crisis, there's permitted disclosures for central registries and PDMPs. So treatment programs will be permitted to enroll and report data, although it is still with patient consent, to the PDMP. And then non-treatment providers will be able to query a central registry to determine whether or not their patients are already receiving treatment through another program. And then finally, disclosures for research will be permitted by a HIPAA-covered entity or a business associate to individuals or organizations that are not HIPAA-covered entities. So currently, research disclosures can only be made to a HIPAA-covered entity. So this changes that and more closely aligns with HIPAA for research purposes. Let's see, I think that is it. So I will turn it over to Mark to talk about the California landscape. Mark, are you still with us?
Yeah, I'm here. Sorry, I just was on mute.
That's okay.
So I'm going to talk about some changes that are in active motion now related to really focusing for the most part on the upcoming Medicaid or waiver. But I want to start out just with a quick note on this next slide that there is a behavioral health task force that is being convened and that will be addressing a broad set of issues in the realm of behavioral health. And Karen, where can people go to learn more about this task force and how to either listen in and follow that discussion?
Yeah, that's so there is this task force is being led by the California Health and Human Services Agency, and so they have more information on their website. I did see it yesterday. This was out of the governor, one of the top 5 healthcare priorities in the budget that the governor issued last week. And it's designed to really help county behavioral health systems address urgent mental health and substance use disorder needs. One of the things that I found most interesting, and I will be watching closely, is that, among other things, they will advise on the Lanterman-Petra-Short Act. What that means remains to be seen, but I think the fact that this group will be charged with looking at the LPS Act, and for those who may or may not be familiar, Lanterman-Petra-Short Act is the California law that regulates certain mental health information, among other things, and it is severely outdated and does not even align with the CMIA here in California. So the fact that this group will be charged with taking a look at LPS and potentially advising on how to make changes to that, I think is a really big step in the right direction.
Great. Thank you, Karen. So let's go to the next slide. Another key priority for the governor is investing in what is now called Medi-Cal Healthier California for All. So Medi-Cal Healthier California for All is also a program formerly known as CalAIM. If briefly, you may be familiar with it under that name. And this is the Department of Healthcare Services framework for Medicaid waiver for 2021 through 2026. And the primary goals are to identify and manage member risk and need through whole person care approaches that address social determinants of health, to move to a more integrated Medi-Cal delivery system, and then to implement payment reforms to incentivize improved outcomes. Let's go to the next slide. The participants, so the following slides all focus on Medi-Cal Healthier California for All. If anyone has a good acronym suggestion or short version, please send it to the state. I think we would all benefit from that. So the participants in Medi-Cal California Healthier for All are the broad sector of stakeholders that serve Medi-Cal beneficiaries. And the key sort of central node for administration services and contracting then out to other partners will be Medi-Cal managed care plans. And in different counties, there are different arrangements for Medi-Cal managed care plans, from single plan counties to 2 plan counties to counties that have multiple plans. Counties and public hospitals, as well as clinics and service providers across sectors, will all be key partners. Counties and public hospitals have been a big part of the current waiver. Counties through the administrative, in many ways, but including including through the administration of the Whole Person Care Program and public hospitals through the PRIME program. And they will now be partnering with Medi-Cal managed care plans as those efforts such as Whole Person Care and the Health Homes program get rolled into Medi-Cal California, Healthier California as well. So initiatives and reforms are taking place in managed care, but also behavioral health, dental, and in some other areas. I'm going to give a quick overview on the next slide of the heart of the program, which is population health management. And so the Medi-Cal managed care plans are being asked to really increase their work to manage and promote positive health outcomes for their attributed members in their service areas, and not only themselves, but through partnerships with the healthcare delivery system, and also organizations such as housing services providers that impact social determinants of health. The population health management program has a number of elements, including two key elements are case management, which has some sort of more traditional medium to high risk basic and complex case management services, as well as then another major part of the overall program, which is enhanced care management, which is for high risk, high need Medi-Cal beneficiaries, and really will pick up where the Whole Person Care program, the Whole Person Care program in many ways is a foundation for enhanced care management, as are other programs such as health homes. And then there's another major area under pop health management that is, or linked to pop health management, which is called in lieu of services, which will take, I think, a longer period of time to really understand what it will look like. There's more flexibility for in lieu of services, but the general idea is that Medi-Cal managed care plans and their partners can propose to DHCS interventions and activities that would replace or reduce, let's say, acute encounters or hospitalizations, and shift dollars upstream, as it were, through different types of services that will then result in cost savings elsewhere in the system. Let's go to the next slide, Karen. So, thinking about behavioral health in particular, there's some key areas where there's going to be impact. The first is in sort of a separate waiver called Institutions for Mental Disease and SMI, an 1115 waiver. I'm not really going to talk about that. I'll just say that partly because it's administratively, at least to me, it looks complex and I don't fully understand it, but the general idea is to bring in federal dollars to cover some county services that historically and currently counties bear the full cost of today. So that waiver should bring in additional federal dollars. And then we'll talk a little bit about behavioral health payment reform, and then the role of behavioral health providers in the context of the enhanced care management effort that, as I just mentioned, is a part of the overall population health management program. And both of those, I believe, are on the next slide. Yeah. So in terms of behavioral health payment reform, there's some really interesting developments related to potential changes in the way that medical necessity is determined that, if these go through, will give more flexibility to behavioral health providers to provide services prior to going through an authorization process. So to be more responsive from a time perspective to their clients' needs. There is an extensive slide deck from DHCS. Let's see, medical necessity criteria. I have a picture of the cover here, and you can access that on the Medi-Cal Healthier California for All website. These slides both sets of slides here were presented in the context of stakeholder groups that are supporting that program. So I would encourage you to go to the website there and check out that presentation if you'd like more information. There also is related to that work is a move toward a more standardized level of care assessment tool across the behavioral health system, and then this third item in the context of administrative changes that the state is intending to roll out as a part of this program. A very big deal in my mind is the integration of specialty mental health services and substance use disorder services. And so for many counties operate both of these two, and they are separate organizationally. They are separate in terms of their EHRs, and they typically have very limited data sharing between those programs. And the goal is over the course of the next waiver to bring them together administratively, and that will then also result in integration in terms of technology and policy. As Karen, if you think back to Karen's presentation on the changes with 42 CFR Part 2, we hope that the changes at the federal level for 42 CFR Part 2 happen quickly enough and go far enough to be able to really enable this integration at the county level, funded and promoted and acquired through Medi-Cal Healthier California for All. And then finally, on the right, there's a quote here that I pulled out from the state's proposal, the Medi-Cal Healthier California for All proposal. And this links back then to the enhanced care management component of that program. And really what's, I think, fascinating here is that the state is saying that county behavioral health staff are really going to be the default care managers, or the default source of care management and care coordination services for the clients that they serve, with some criteria here related to diagnosis. But this will be many people in the safety net, and those staff will be asked to, and the departments will need to agree to coordinate all the services, so physical, developmental, oral, or long-term care needed by those populations, not just their behavioral health needs. So they're basically saying, and they actually spell this out, how managed care plans, we expect that you will contract with county behavioral health departments to provide care management services, not just related to behavioral health, but integrated care management services that start with behavioral health and then expand out to cover all of these Medi-Cal beneficiary needs. That will be a new role for many behavioral health departments, and DHCS is aware of that and is thinking about how to create and foster the development of a workforce that can think across sectors and support the coordination of services across sectors for Medi-Cal beneficiaries. This will also involve then a new relationship between Medi-Cal managed care plans and the care management programs that they are building and counties. So I think it's super exciting, and of course counties will have the opportunity to decline to do this, but we certainly hope that they step into this role and partner with the Medi-Cal managed care plans to provide these services, because it does seem to us to make sense that for individuals with a primary mental health and illness diagnosis, having a care manager who really understands that issue, coordinate their care more broadly, really makes a lot of sense. So we think it can help put behavioral health at the center of healthcare and services across sectors more generally. with that, we are done with our presentation. And David and team, back to you. We'd welcome any questions now, and certainly welcome any questions either that you can afterward, David, or that are emailed to us.
Great. Well, thank you, Mark and Karen, for that very informative presentation. I know it's a lot of information, and so you probably had to go through it quicker even than you wanted to, but definitely I encourage folks to follow up with Mark and Karen and their team for more information later. And we have, looks like about 10 minutes, and we have had some questions roll in. So I will just go through these quickly. And the first one is, it's really more of a comment than a question, but I think it's something we hear a lot in the BH space. So maybe Mark and Karen, you can just respond to this from what you've seen, or if there's advice you would give. But one of our listeners stated that often data sharing is limited by the type of EHR you utilize and the inability for different platforms to sync.
Yeah, I think generally that's absolutely true. And we, as does CalHIPSO, we always promote standards-based technology and standards-based approaches. And there has been progress in the requirements from ONC and otherwise on EHRs that is making it easier for them to be connected. But there's certainly a long road ahead, as we all know. I think that the emergence of national networks such as Care Equality and eHealth Exchange and Commonwealth nationally are really starting to make an impact, and aligned with, in many cases, regional HIEs in California. So, yeah, that's totally true. And there's certainly more work to be done there. I think we're going in the right direction.
And I think it's, at least from CalHIPSO's experience, it's a particular bugaboo in BH information where I know we've encountered a lot of clinics that, because of the concerns about data sharing rules, run parallel systems, for one for BH and one for medical, and they're not even able to share data within their four walls. I mean, it is something where I agree we've made progress, but there is still a long way to go.
There are, yeah. And so, David, I think at least in terms of county systems, and others, the larger provider networks that they contract with for behavioral health, we're over partly through it depends on what the dollar figures are, but at least the state and CMS's intent is to force through funding and regulation changes to address that issue. And it's makes sense from a policy perspective, and of course the devil will be in the details of how that attempt gets rolled out.
That's great. Next question. Listener says, I'm new to the nitty-gritty of 42 CFR Part 2. What about integrated primary care providers who are administering MAT, medication-assisted treatment, for example, in their primary care? So it's not a separate treatment facility or location.
Yeah,
that's a great question.
Go ahead, Karen.
Excuse me. Thanks, Mark. There's actually a white paper that MNAT and CHCF funded a couple of years ago that specifically talks about those challenges. And, the guidance there is really that, it goes back to how the organization holds itself out. So if it's truly a primary care practice and they're not holding themselves out as solely providing those services, then they would not be subject to 42 CFR Part 2. Now, in the case that the listener was bringing up, it's possible that if there's a particular unit in the clinic or one particular provider, that's all they do, then that could be seen as holding itself out. And so that particular unit or that particular provider could potentially be subject to Part 2, but not necessarily the entire primary care clinic.
Yeah, and I think they could go to their compliance or privacy and security officer to get clarity on whether their organization is holding itself out as a Part 2 program.
Okay, perfect. Moving down the list, I believe this was referring specifically to one of your slides, so hopefully we can trace this back. But one of the listeners asked, can you give an example of consent requirement?
So I'm guessing that is with probably 42 CFR Part 2. And so the consent requirements under 42 CFR Part 2 are very specific. The regulation, the rulemakings that have happened over the last couple of years have tried to both modify those requirements in terms of what needs to be on the form, and also clarifying what is in existing regulations. So, for example, in the past, as I mentioned, the consent form had to not only have the list of, like, for example, a clinic that would be receiving the information, but a particular person at the clinic, so the particular treating provider. And with the most recent change, that has changed to they can just name an entity, hospital or health information exchange or etc., without having to name a specific person at the organization that will receive the data.
Okay, perfect. Moving down the list, because I think we've got time for one, maybe two more, depending on how long the answer to these questions is. One listener asked, how many California counties share behavioral health information today, and is there a list?
There's no list. That's a hard question to answer. I think that most counties share behavioral health information with some partners. A much smaller number share information via a community health information exchange. In San Joaquin several years ago, we were the first to do that. Now via Whole Person Care, if you look, there is information on the 25 or so counties that are engaged in Whole Person Care pilots. I would think that most of them are now doing some amount of behavioral health data sharing. It may be in some cases within their county organizational structure and their contracted providers, but we know of probably a third to half of those. There is some sharing of information beyond that. Karen, am I wildly off, do you think?
No, I think you are not wildly off. I think, as you said, it's really hard to quantify that, and it really just depends on how we define sharing. But in the context of whole person care, I think the vast majority have some sort of a behavioral health component to it.
And I think so. That's the answer for mental health information. For 42 CFR Part 2 substance use related information, it's like none, basically. It's like down to like one or two. We're Alameda is almost there. LA may have gotten there. I'm not sure. but it's a very small number if we're talking about Part 2 data. But it's going in that direction. Sorry. Okay, David. We're at the top of the hour.
Yeah, we are at the top of the hour, and I can see in the attendee list that we are losing folks to their 1 o'clock meetings. So if we did not get to your question and you would like to follow up, if you could please send a note to info@calhipso.org, and we will make sure that we follow up with you, and we can route questions to the appropriate place over the next couple of days. So I will remind everyone, yes, these slides will be available. We will post a recording of this webinar to the CalHIPSO YouTube channel, and we will link both the presentation and the YouTube recording to the CalHIPSO website over the next couple of days. Give us 24 to 48 hours to get it up. And so you can look for that there, or if your colleagues who didn't make it today and you want to show it to them, we love that. So with that, I will give a big CalHIPSO thank you to Mark Elson and Karen Boruff from Intrepid Ascent for being our faculty on today's webinar, and for sharing your expertise with CalHIPSO enrolled providers. And we will bring the webinar to a close. Thank you, everyone, for attending.
Thank you.
David, thanks, everyone.